My name is Rob Cronin. I'm an assistant professor over at Vanderbilt, work with the DRC, and also am one of the what we call PPI, Participant Provided Information Co-Chairs, which is basically a fancy word for the survey co-chairs. So I've been working with the program kind of since its inception, working on developing, testing, evaluating these surveys, and also working on the workbench from the survey standpoint. So really appreciate everyone who's here. Appreciate the time to talk with you all about the All of Us survey data. And I think with that, I'll end up kicking it off. If we go to the next slide, so we're going to talk a bit about the survey development. We'll also talk a little bit about where they are on the workbench and some information around them, and and how to kind of look at them both from the Survey Explorer and from the workbench. So first, a little bit about how we develop these surveys. First, why develop surveys, right? We have a bunch of EHR data, so why not just use that? Because there are certainly some things that the surveys can add to EHR data. So in terms of EHR data, we don't collect a lot of social determinants of health data. Oh, yeah, I'm still on the first slide. I'm just kind of talking a little bit more about the importance of surveys. Back one more.
I'm sorry.
So yeah, you're okay. So EHR data, they collect a lot of personal medical history, medications, things along those lines, but don't quite collect things like social determinants of health. And also certain EHR data may not give the true information or all the information. So things like smoking history and things along those lines can be augmented by the EHR information. Can we go back one more slide? So between the two, asking surveys can help us add in more information and also can help us understand the truth a little bit better, because as we know, personal medical history and family medical history is obtained in the EHRs, but asking participants could give us more information than what we get from just EHR data. Another important thing is we certainly want, surveys traditionally are things that there's a lot of methodology into developing a survey. So a survey is not something you just come up with a bunch of questions and ask people. There's so much that goes into the types of questions you ask, how you ask those questions, the orders that you ask those questions. All these things are really important in trying to get at the information you really want to get to. So what we try to do is leverage. So there's a lot of research that goes into developing a survey. So we try to leverage what other people have already done, because like I said, it takes a lot of work to create a survey. So we try to take surveys and questions from places that they've already been well validated and well tested. So that our surveys, one, will get the information that we hope to get. And two, we can also look at how our surveys and our responses look at, and our population look at, compared to other populations of other large national studies. And then even though we use that and try to leverage the information, the qualitative and quantitative information, our population may be a little bit different than the folks who may have gotten those questions before. So we also do some qualitative and quantitative methodology of pilot testing these questions. So before the questions are put out into the actual All of Us research program, we'll do some extra pilot testing, having folks go through the questions and read the questions and think through something we call cognitive testing around the question, so we can make sure that in the various populations that we get, the underrepresented in biomedical research, that these get the information that we would expect them to get, the surveys. And we also, we'll go to the next slide, we also look at quantitative, so how long it would take for folks to answer questions, as well as some other metrics. So principles and action. So this is the actual development process. So it starts with content development. So, how do we got to get those questions, right? And we got to build out a module or a survey, whether you're looking at healthcare utilization or social determinants of health. Before that, we want to prioritize the domains, right? So we can ask questions on lots of different things, but the question is, what is the most important information that we want to get from our population? So we want to prioritize, is lifestyle, meaning, things like tobacco use, alcohol use, and drug use, is that important? And how important is it? So kind of at a program level, we determine what are the most important domains. And then once we know what the most important domains are, let's say, for example, lifestyle, smoking, tobacco use, alcohol use, and drug use, we then develop, kind of a group to go and look at all the measures that exist out there, because obviously there are lots of ways that you can ask these questions. So we review the related measures and figure out, what might be the best measures that get at the information we want. Again, trying not to change those questions and responses. This way, we can use what folks have already done in terms of validating their surveys. And then we create this module that has these questions in them, and we do it in English and Spanish. So a lot of times there may be a translation that exists. We'll try to leverage it. If not, then we'll do our own translations and review it from English into Spanish. So that's first, is developing that, and then there's a process to make sure that there's groups of folks who make sure that the content, the domains, are ready to go to the next step. That's at certain committee levels, and then becomes the pilot evaluation, as I was alluding to earlier, where we do those cognitive interviews, asking people to go through it, making sure that the information is understandable, that the information is not too confusing, it's not too delicate. It's not asking questions that are going to make people say, I'm not going to take any more of these survey questions. And then some of that quantitative online testing, where we look at the distribution of answers in a small pilot study. Again, it's not going to be the hundreds of thousands of people we get the final answers on, but a small group of folks to kind of see how long it takes, as well as making sure that everybody doesn't select the same answer, meaning that the question really doesn't work well. And by using previously validated instruments and survey questions, we usually don't see that. Then we finalize, so that all that information, that pilot testing goes back into the program to make sure that there aren't things that we've seen, that we see that are issues. So we've seen tons of things in some of the survey questions. Some of the big ones are, one, a lot of these questions are done by interviewer surveys, meaning that there's somebody reading you the question. So the language may not seem quite as right if it's a self-directed survey, where a person is reading you something versus you reading it yourself. So there's some little things like that. There's also some areas that do cause some confusion in certain populations. So we'll add more help text, or, not really change the question, but add some more text beforehand, or help text to help them, figure out orient to what what kind of information we're really trying to get at. And then also there's some other, minor modifications. I could think of one where we asked about cigarettes and people didn't know how many were in a pack. So, it was helpful to give that extra information in there. Once that, again, that's reviewed by all the stakeholders, then it's either could be retested. So we've had issues where, or times where it's like, well, I've made all these changes, maybe we added more questions or something like that. We probably should reevaluate this questionnaire because it's a bit different than what it was before. But if it's just some minor things like, changing the way that it looks like from an interviewer to what it looks like on a computer, then we may not retest it. The other thing that's important that we noticed from the testing is the fact that putting it on a smartphone or on a tablet or even a computer, it can, the way that it's displayed may be different than what it might look like on paper. So we actually learn a lot about, kind of what people are actually going to use when they get into the portal. And then we deploy it. So then we release it onto the participant portal, and folks end up answering the questions. Let's go to the next slide. So these are the surveys that are currently out there. First column are the different surveys. The second column are the domains. I'm going to go through these in a little bit. Third is the eligibility. So when are you eligible to answer the questions? And you'll notice that they're not all available right off the bat. And the last one is, how many folks have we had answer these different questions? So, the first three there, basics, overall health and lifestyle, the three domains, those kind of hit your socio-demographics, your general well-being, some female reproductive health questions, and then that smoking, alcohol, and substance use. Those are all three of them are available at baseline, meaning when you walk in the door, you're getting recruited, all those three questionnaires are available. You'll notice a slight drop off from basics, overall health and lifestyle, but overall, and these numbers are in the most recent release of the CDR, I do believe. So, there are more folks that, in new updates, there will be more folks that'll be in there. But you can see for the most part, people are answering all three of those questions at baseline, meaning, when they're first being recruited, they'll answer them. The next three that you'll notice, healthcare access and utilization, family medical history, and personal medical history, they almost cover exactly what they say. Healthcare utilization and access, history of medical conditions, and history of medical conditions of the family and of the participant. They're optional, right? So, the first three, certainly the basics, you have to, in order to become a core member, get all your biospecimens and things along those lines, you have to complete the basics. But these modules or surveys are optional after 90 days. So if you walk in the door right now, with COVID, before pre-COVID, if you walked in the door, you would only see the first three surveys. And then 90 days later, these surveys would open up for you. You notice that the current participants is a significant drop off on that. We know that, and we've been working hard at trying to improve that. Again, this is older. These are numbers are slightly older, so we have seen some improvement in that. And what I mean by optional for modules 4 to 6 is that basically there are no real requirements to join all of us, right? But there are some requirements to have your biospecimens drawn. And then you obviously have to do things like releasing your, options of releasing your EHR. What I mean by optional in this case is just the fact that you're past that recruitment stage. And at that point, you're a participant of all of us, but you don't really have to do much more stuff once you've given your biospecimen and done your physical measurements. So that's really what I mean by optional, is that, you can continue to be a participant in the All of Us research program, although at that point, but you don't have to answer any more questions. Whereas in the basics, you have to answer them. It's all voluntary, but you have to answer them in order to get your biospecimens drawn. So again, this is a major area that we're working on, is in and around having folks complete these follow-up surveys. But it's something to note when people are analyzing data, and a lot of it is around UBR populations that we have much lower, people completing these surveys. And then the final one is the COVID-19 participant experience. So that's the COPE survey. You'll hear me say COPE multiple times. That's the COVID-19. And it's looking at the impact on the pandemic on mental and physical health. And again, if you walked in the door, you can't say pre-COVID, but if you walk in the door tomorrow or in a month or in 5 months when COVID may be better, after you complete the basics, you can do this module if you wanted to. Right now, there's nobody in the registered tier with it because it's a new survey. But it will be released in late 2020. I will say the numbers are not going to be 220,000, but probably somewhere on the order of that, of what we're seeing of the more recent modules of the 30 to 40,000. Let's go to the next slide. The resources, so here are some of the resources for exploring All of Us at the All of Us Survey Explorer. So you can see what every single question is that are asked of participants, every one of them, and from English and Spanish versions. And you can see those are the 6 there. The COPE one is coming, it'll be coming to a store near you, so to speak. The other thing that's unique about COPE that I do want to let you know about is that we actually released a different, a very similar, and I don't want to say different, a very similar version of the module month after month. Really very minor changes, but there'll actually be, there's multiple versions of that module, so to speak, or multiple time points. Let me say it that way. Multiple time points when that module was asked of participants. So, we're working on kind of getting that all put together. The other thing that's important is that there are a lot of original source information about it. So with each question, as I mentioned, we try to take from previously validated or national studies. So you can explore the source material and learn a little bit more about, when the questions were first published, some summary information, and possibly even a URL of where those questions are located, so you can go to that study and find the original questions, so to speak. If we go to the next slide, and then that you can see over there that there's a link as well to that. So there is, and I apologize about this, is clearly I think a Microsoft to Mac thing. I had downloaded the slides and sent them. So this might be, I apologize about this slight, the way that the slides are slightly off. So this development process that I kind of gave an overview about, we go into a bit more depth. There's a paper that's been published in epidemiology. It's now on PubMed Central. So everybody has access to it. It describes the methodology of the pilot as well as the development of those first 3 modules. The other thing that we're in process of is exporting all of these into a REDCap shared library. So for folks who use REDCap or institutions that use REDCap, you'll be able to download, kind of just like other instruments like PROMIS or other types of things like that, be able to download from the shared library these modules. And we'll have English and Spanish versions. As mentioned, it's, if your institution has a REDCap license, you can have access. If you don't, I would talk to your institution about gaining access. And the All of Us COPE survey, that COVID-19 survey, is already available with others to follow. We can go to the next slide. So the other thing that's important is, how is this represented in our registered tier, right? I mean, there's one thing to say we've got these questions and answers, but how do we put that into something that researchers can use in the registered tier? So really what we've done here is we leveraged the observational health data sciences and informatics, the Odyssey vocabulary. You can see a link there that you can go to that allows you to explore the library. It has, it's the OMOP kind of a common data model that everything is mapped to. And again, like I said, you can search through Athena, the Athena website there. Looking at the almost flow chart here, you can see, so for example, there's a question in there, asks about annual income, and there's a response that says my annual income is from 10,000 to 25,000. So that response is mapped to a certain concept ID, 1585377. So every single answer is mapped to a concept ID in a table, in what we call a PPI table, the participant provided information, which is really like the survey table. Now, whenever we could, if that question was from a validated survey, sometimes those things would be mapped to a standard terminology like LOINC. So if we can, we would map the condition ID to a LOINC code. And then also that standard concept ID, the 46235,933, which is basically the concept ID in OMOP that stands for that LOINC code. So this will allow you, if you wanted to compare to, other responses from other surveys that you map to that LOINC code, there's always that possibility. So wherever we could, we tried to map to a standard terminology so that we can have more interoperability. There are reference guides, which I'm going to kind of run through here in a little bit, and a research support hub, as well as some tips and tricks for extracting, working with data, and looking at participant counts in featured workspaces. So if we go to the next slide, which I think should be the resource center. So this is on user support. If you're in, this is a screenshot from the Researcher Workbench. If you go into user support, here's some documentation. So you can look at resources for survey research data where they talk a little bit more about certain things like survey codebooks. To help researchers understand more about the surveys. If we go to the next slide, and there's lots of good stuff in there. There's also, as I was mentioning, some featured workspaces. So example code that you can go and look at and use and work from that talk about, that kind of look at the different data sources and including the survey data. So if you go to your Research Workbench workspace library, you see the tutorial workspaces on the left there under the hamburger, those 3 lines. You see we're on tutorial workspaces, that there is a workspace in there that you can go to help you learn how to work with the All of Us survey data. Go to the next slide. The other thing that's important in the registered tier is the fact that we had some privacy some privacy rules that we use, because the registered tier is really available to a wider population. We want citizen scientists. We want everybody, a lot of folks, not Survey Explorer where you could see, where anybody could see it, but, going through a certain set of credentialing, so to speak. But a lot of folks are going to end up seeing the registered tier. So the program wanted to make sure that you couldn't easily re-identify somebody. So you wouldn't know you wouldn't be able to do some things and be able to determine that this person is John Smith, who may be an elected official or something like that. So we wanted to make sure that we protected participant identity. Or he's not an elected official, he's your next door neighbor. We wanted to protect people's personal identifiable information, or it's you. We wouldn't want other people to identify you if you're in the program. So there are some things that are suppressed. So, things like race and ethnicity, there are some people who may click lots of different race and ethnicities, and there are not many people who are going to click lots of different race and ethnicities, of how they identify themselves. So you may be able to find out who that person is. There's a lot of information in that documentation. Before, we were looking at resources here. We're looking at the participant privacy protection. So you can read through, there's a lot of good information there about, some of the important policies that are in there, as well as some of the generalizations that were done. So I'm not saying there's no race and ethnicity data in there. There's a lot of race and ethnicity data in there. It's just you can't get all the data. So the person who selected 5 different things may come off as more than 2 or more races, or a combination of races, not necessarily all those different selections. If we go to the next slide, but it does still allow for a lot of research to be done. We've worked really hard with our science committee and the privacy folks to make sure that it's not that we're inhibiting research. So there's still a lot of research that can be done in populations like the Hispanic population and folks along those lines. So here are some ways that things have been kind of generalized, so to speak. Basics questions: which of these categories describe you? That's the race and ethnicity question. Select all that apply. So, if you selected one of some of these, if you selected Middle Eastern or North African or Native Hawaiian or other Pacific Islander, or none of these fully describe me, what you're going to see is another single population. So, and you can go through and see what the generalizations are, just because we don't have a lot of Middle Eastern and Northern African people. So if you selected that and you had a certain age and you had a certain education and certain sets of things, you could potentially tell who that person is by, that's why, because of the people who are in our All of Us research program, we generalize some of these things. So to describe it again, so if I was a participant and I selected Middle Eastern and North African, what you as the researcher would see on the registered tier is another single population. So I could have been, so from your standpoint, I could have been Middle Eastern or North African, I could have been Native Hawaiian or Pacific Islander, and I could have been none of these fully describe me. 2 or more of the following. So now if you had selected white and Asian, you'll end up seeing more than one population. So you'll know that there are multiple populations. You may not know exactly which ones were selected, again, to protect the privacy of the person, because I wouldn't want people to be able to look at all my health information, right? Because once you identify who I am, you could look at my EHR data, which is protected, and I personally wouldn't want folks going through my electronic health record data. So we wanted to protect people in that respect. Next slide. Instrument scoring. So another kind of unique thing that we have in the registered tier that's coming up, it's not in there yet, but it's coming, is scoring of different measures. So traditionally, in research, you might be, if you ended up using a certain instrument, there's usually directions of how to score it, and then you would have to score it yourself. So we're working on trying to create these scoreable survey measures so that folks to have more of more standardization. So making sure that, in certain places they can be a little tricky of how to score them. With some things you have to map the tables, and some things you have to invert the scoring. So there can be a lot of things that can be tricky with scoring surveys. So we're working on these different ones that currently exist, as well as some newer ones, to enable researchers to be able to do this type of research and score these instruments and have good, reliable scores that they can use in their research. Certainly, of course, you could still get the original questions and you can still score it yourself if you'd like. But, again, this is all about enabling research and trying to help researchers be able to do the research they'd like to without having to do potentially either A, all the extra legwork, or B, making it too confusing where they won't even approach different scoring measures. So the ones that we have that are coming soon because they exist in our original surveys are the brief health literacy screen, so which looks at people's health literacy, and then the PROMIS, the patient reported outcomes measurement instrument system, the PROMIS mental health and physical health, as well as the Audit C, which has to look at alcohol use disorders. There are 9 more to be included from the COPE survey and that we're working on. And then, as mentioned, there'll be a new featured workspace with the resulting scores for scorable measures planned for the release of the next registered tier of at least the 4, so that you'll be able to go right to a workspace and be able to, pop the code out or whatever you'd like to do to be able to score these different measures. If we can go to the next slide. So, and here's an example of, some of these, they have a raw sum score. This is global health, the physical and mental health. You grab a couple of their responses. There's a sum score. It leads you to a T score on a scale, a scale of 1 to 100. Where do people lay? We will make it easy and available for researchers to just be able to plop some code and be able to get the T scores. This way, instead of it being a raw sum score that may not make as much sense, you can say on a scale of, on your bell-shaped curve, where approximately does the person sit? Or where does your population sit as compared to another population or whatnot? And there's a source down there that folks can look at for the global scoring manual. If we can go to the next slide. So what's next? So there's a lot of stuff that's that's kind of a lot of description of one data type and kind of the things that are available. But we're working on a whole bunch of other things with the next scheduled refresh, which again should happen later this year. A lot of the COPE responses will be available. Again, there'll be some things that may be modified based on privacy concerns, but we're going to make a lot of things available from the COPE surveys. And then, of course, there'll be additional participants' data. So the other thing that that always to keep an eye out for is as we get higher numbers of folks, some of those privacy concerns may not exist anymore. So, if you can imagine if we had the same number of Middle Eastern or North Africans as we had of white or African American folks, then we may be able to not have to generalize that anymore. So, there may be additional participant data, not to mention the fact that I mentioned earlier, we had about 230,000 on there, but there's going to be a bunch more folks who have taken the surveys that we're going to be putting into the refresh. There's a pipeline here I didn't really have time to describe that makes sure that the data that you all see as researchers is cleaned, is reasonably cleaned and understandable. So we don't want, there's some nuances between the systems that we want to make sure you don't have to necessarily worry about when getting the data. I'm not saying that we're scrubbing data and removing a bunch of data that would be important to researchers, but there's certain things like having strings in number places, even though we've worked on that in some of the older data, just making sure that data is appropriately cleaned and the privacy rules have been applied before they're available. So that's why there's not necessarily every single piece of data that a person puts in is available right away in the registered tier, just because of certain privacy concerns and things along those lines. But that's why more data will be released in the next refresh. And in the future, there are more surveys coming out. So we are delivering more surveys and working on making sure as many people fill those surveys out as we can, including, I mentioned social determinants of health is just fresh in my mind because we're just getting ready to go into some pilot testing and planning on releasing that sometime over the next 12 months, as well as environmental exposures and physical activity and diet. And then the other thing is, I mentioned that COPE had, different time points of the same questions. We want to do that for everything because some folks have been in the program for, a year or two. So we want to ask them those questions again because, as I'm sure we all know, people who smoke may not smoke forever, or people who didn't smoke may start smoking. So we do want to get reassessment of folks which is another thing that will be coming soon to participants, which will eventually end up in the registered tier. I think that's everything that I've got. I look forward to any kind of feedback and/or questions that folks have. And with that, I'm going to stop.